Module 9 UHS Modular Integrated Undergraduate Curriculum. Physiology Sheikh Zayed Medical College Physiology Department. Dr. Sheen, CEO and founder, Medical Superfast Simplified Physiology Video Lecture Notes. Guyton and Hall 14 edition lecture number 21 chapter 39 page 507, 508 and 509. Learning objectives. Explain pulmonary capillary dynamics. The dynamic involves forces and motion of fluid exchange across. Lung capillary membranes are qualitatively the same as peripheral tissues, but quantitatively there are important differences. Pulmonary capillary pressure is very low, about 7 mmHg, in comparison with capillary pressure in the peripheral tissues that is about 17 mmHg. Interstitial lung fluid pressure is slightly negative than that in peripheral tissues. Pulmonary capillaries are more permeable to protein, so colloidal osmotic pressure is about 14 mmHg, with less than half this value in peripheral tissues. The alveolar wall is extremely thin, and the alveolar epithelium covering the alveolar surfaces is so weak that it can be ruptured by any positive pressure in the interstitial spaces greater than alveolar air pressure mmHg, which allows dumping of fluid from the interstitial spaces into the alveoli. The alveolar walls are lined with so many capillaries that in most places the capillaries almost touch one another side by side, that the capillary blood flows in the alveolar walls as a sheet of flow rather than individual capillaries. Dynamic force of fluid across pulmonary capillary. Forces tending to cause movement of fluid outward from the capillaries and into the pulmonary interstitium. Capillary pressure 7. Interstitial fluid colloid osmotic pressure 14. Negative interstitial fluid pressure 8. Total outward force 29. Forces tending to cause absorption of fluid into the capillaries. Plasma colloid osmotic pressure 28. Total inward force 28. Total outward force plus 29. Total inward force minus 28 equals plus 1 mmHg. Negative pulmonary interstitial pressure and the mechanism for keeping the alveoli dry. This filtration pressure causes a slight continual flow of fluid from the pulmonary capillaries into the interstitial spaces, and except for a small amount that evaporates in the alveoli, this fluid is pumped back to the circulation through the pulmonary lymphatic system. The pulmonary capillaries and the pulmonary lymphatic system normally maintain a slight negative pressure in the interstitial spaces. It is clear that whenever extra fluid appears in the alveoli, it is sucked mechanically into the lung interstitium through the small openings between the alveolar epithelial cells. Then the excess fluid is either carried away through the pulmonary lymphatics or absorbed into the pulmonary capillaries. Thus, under normal conditions, the alveoli are kept dry, except for a small amount of fluid that seeps from the epithelium onto the lining surfaces of the alveoli to keep them moist. Implications of Starling law. Pulmonary edema. Pulmonary edema occurs in the same that edema occurs elsewhere in the body. Any factor that causes the pulmonary interstitial fluid pressure to rise from negative range into the positive range will cause rapid filling of the pulmonary interstitial spaces and alveoli with large amounts of free fluid. The most common causes of pulmonary edema are as follows. Left-sided heart failure or mitral valve disease with consequent great increase in pulmonary venous pressure, and pulmonary capillary pressure and flooding of the interstitial spaces and alveoli. Remember that every time the left atrial pressure rises to high values, the pulmonary capillary pressure rises to a level 1 to 2 mmHg greater than the left atrial pressure. Damage to the pulmonary blood capillary membranes caused by infections such as pneumonia or breathing noxious substances such as chlorine gas or sulfur dioxide gas. Each of these mechanisms causes rapid leakage of plasma proteins and fluid out of the capillaries and into the lung interstitial spaces and alveoli. Pulmonary edema safety factor. Experiments have shown that the pulmonary capillary pressure normally must rise to a value at least equal to the colloidal osmotic pressure of the plasma inside the capillaries before significant pulmonary edema will occur. Therefore, in the human being, whose normal plasma colloid osmotic pressure is 28 mmHg, one can predict that the pulmonary capillary pressure must rise from the normal level of 7 mmHg to more than 28 mmHg to cause pulmonary edema, giving an acute safety factor against pulmonary edema of 21 mmHg. Safety factor in chronic conditions. When the pulmonary capillary pressure remains elevated chronically for at least 2 weeks, the lungs become even more resistant to pulmonary edema because the lymph vessels expand greatly, increasing their capability of carrying fluid away from the interstitial spaces perhaps as much as 10-fold. Therefore, in patients with chronic mitral stenosis, pulmonary capillary pressures of 40 to 45 mmHg have been measured without the development of lethal pulmonary edema. Rapidity of death in acute pulmonary edema. In acute left-sided heart failure, in which the pulmonary capillary pressure does rise to 50 mmHg, death occurs in less than 30 minutes from acute pulmonary edema.